ఓపెన్ చేసుకొని స్టార్ట్ చేసుకోండి. నేను ఆల్రెడీ స్టార్ట్ చేశాను.
డైరెక్ట్ చెప్పేయచ్చు. పవర్ పాయింట్ ఓపెన్ చేసి
వచ్చేస్తుందా డైరెక్ట్?
వచ్చేస్తుంది. పవర్ పాయింట్ ఓపెన్ చేస్తే
నేను దీంట్లో పట్టట్లేదు. ఈ కనెక్టర్ లేదు కదా అది. నేను స్టార్ట్ చేయాలి. స్టార్ట్ ఏం కాలేదు. Good morning everybody. Today my topic on infective endocarditis. Infective endocarditis is the infection of endocardial surfaces of the heart. It is characterized by colonization and or invasion of the heart valves, either native heart valves or damaged heart valves, that is prosthetic, or the mural endocardium by microbes, leading to the formation of vegetations. The vegetations containing platelets, fibrins, inflammatory cells, and it may leads to the destruction of the valve or change in the valve. So most commonly involved is heart valves, that is ventricular septal defects, mural endocardium, intracardiac devices, Anlag's process involving arteriovenous shunts and arterioarterial shunts and coarctation of aorta. So infective endocarditis classified according to the onset, that is acute or subacute. Acute is normally it's involved normal valves, not damaged valves. The most common organism is involved in Staphylococcus. It's damaged the cardiac structures and seed extracardiac sites, and if left untreated, progress to the death within 1 to 2 weeks. Subacute endocarditis, it involves damaged valves. Most common organism is Streptococcus viridans. Its damaging is slow process, not like acute endocarditis. In progressive, unless the damage also complicated by major embolic event or ruptured mycotic aneurysms. Next, healthcare associated native valve endocarditis, most commonly Staph aureus, that is Coagulation natives and Enterococci. And prosthetic valve endocarditis, Staph aureus, diphtheriids and fungi is the most common involvement. It is normally arising within 2 months of valve surgery, generally nosocomial. Incidence: infective endocarditis is the most dreaded complication its most common incidence. The incidence is 4 to 7 cases for 1 lakh for 1 year. In developing countries, congenital heart disease and chronic rheumatic heart disease is the most common cause. And in developed countries, IV drug abuse is the most common cause of infective endocarditis. It's seen in elderly patients, and native valve endocarditis is seen in 25 to 35% of healthcare persons and 16 to 30% of prosthetic valves. Prosthetic infections first 6 to 12 months will be greater. So after the prosthetic valve transmission, there is a chance of infection is more. The predisposing factors. The predisposing factors for infective endocarditis is most common in India, in developing countries, the rheumatic heart disease, and followed by myxomatous mitral valve disease, degenerative calcific valvular stenosis, and bicuspid aortic valves and prosthetic valves. Predisposing factors, host factors, mostly immunodeficiency status, that is neutropenia, immunodeficiency, malignancy, immunosuppression, diabetes, alcohol, IV drug abuse. These are the predisposing factors which may lead to the infective endocarditis. The organism which is causing the infective endocarditis is most common organism is Staph aureus. These Staph aureus either healthy or deformed valves, IV drug abusers or devices, anything the affected by Staph aureus. Then Streptococcus viridans, that is natives but previously damaged or abnormal valves. Enterococci, then coagulation negative Staphylococcus, the Staph epidermidis, that is seen in prosthetic valve endocarditis and devices. Then gram negative bacilli and Hackett group of bacteria and yeast and fungi. This is very rare. It causes culture negative endocarditis. Then pathogenesis. Normally the source, the portal of entry is dental or surgical procedures, contamination by IV drug use, obvious infection, that is respiratory or skin infections, and occult source from gut, oral cavity, injury, intravascular catheter infection, nosocomial wounds, and chronic invasive procedures. The mechanism. Initially there is a once the there is endothelial injury. After injury, there is uninfected platelet fibrin thrombosis formed, which may lead to transient bacteremia and attachment of non-bacterial thrombotic endocardium, which the bacteria is proliferation and coagulation state. Then it may lead to the infection and friable and bulky vegetations. The vegetations are the embolic source. So friable bulky vegetation contain fibrin, inflammatory cells and microbes and platelet-rich cells also. The aortic and mitral valve is the most commonly involved valves, and the right side valve involvement seen in IV drug users. So in rheumatic heart disease and infective endocarditis, there is a at a single place there is a big thrombosis form, and Liebman sac endocarditis seen in SLE, systemic lupus erythematosus. It is seen in underneath the cusp of the valves. And the symptoms. And this is very important. The symptoms are, most common symptom is high grade fever. Fever with, it is one of the diagnosis for fever with chills, and shortness of breath, arthralgias, myalgias, and abdominal pain, pleuritic chest pain, and back pain. And subacute symptoms are low grade fever, anorexia, weight loss, fatigue, arthralgia and myalgia, and abdominal pain. Then the signs. Signs is there is a change in heart murmur. Initially, the onset of new murmur or there is a change in the heart murmur is the classical sign for infective endocarditis. And there is a oscular nodes, Janeway lesions, and Roth spots. These are all present in infective endocarditis. And petechiae, sphincter hemorrhages, clubbing, splenomegaly, and neurological changes also seen because of the embolic episodes and abscess, cerebral abscess also. So this subconjunctival hemorrhages and murmur, this I already told, there is a varying murmurs. 80% of new or changed murmurs, and conduction disorders and cardiac failure, congestive cardiac failure, and there is a hematuria, oscular nodules, petechial rash, cerebral emboli or cerebral abscess, Roth spots in fundus, and petechial hemorrhages on mucous membranes and fundi, and poor dentition, splenomegaly, and systemic emboli. Next, digital clubbing, sphincter hemorrhages. These are the general examination findings seen in infective endocarditis. So this embolic lesions, there is oscular nodules. The oscular nodules are painful nodules, which is small erythematous nodules located on the pulp of the fingers and toes. Then Janeway lesions. Janeway lesions are pathognomonic of infective endocarditis. This is non-painful. Oscular is the painful and Janeway nodules are non-painful. Erythematous blanching macules located in the palms and soles. And sphincter hemorrhages. That is late appearing symptoms in infective endocarditis. These represents damage to the capillaries, may also appear due to Nile trauma. Then complications. The complications may be cardiac complications or non-cardiac complications. The cardiac complication is the most common is congestive heart failure and stenosis structural damage of the valves, that is either regurgitations or stenotic lesions, and embolic episodes, purulent pericarditis, and prosthetic dehiscence. Extracardiac complications are abscess. When the thrombus is focused, thrombus or emboli focus in any place, there is a chance of infection and which may leads to the abscess formation. That is splenic. If it is enter into the splenic circulation, it will cause splenic abscession and cerebral aneurysm, cerebral abscess, myocardic aneurysm. Myocardic aneurysm is there is a thin-walled abscess which is ruptured, may leads to the rupture, and extracerebral aneurysms, and there is hypocomplementic glomerulonephritis. This also the thrombus is focused on the glomerulus and it may leads to the glomerulonephritis which may hypocomplementic. And next, empyema or pyoneumothorax. If it is enter into the lungs, it may cause the empyema, pus in the lungs, and pyoneumothorax. And the diagnosis. The diagnosis is very important. There is a Duke's criteria is there in diagnosis of infective endocarditis. The Duke's criteria contain 2 major manifestations and 5 minor manifestations. If the diagnosis is confirmed by if the patient has 2 major or 1 major, 3 minor or 5 minor manifestations. The major manifestations is blood culture is positive for typical infective endocarditis causing microorganism. At least continuously we sent 2 blood samples for 24 hours apart which may positive. Then evidence of endocardial involvement in 2D echo. And minor manifestation is predisposing heart conditions or IV drug abuse and fever with temperature more than 38 degrees or 101.4 degrees Fahrenheit, and vascular phenomena, that is arterial emboli and vascular phenomena, immunological phenomena, glomerulonephritis, Osler's nodules, Roth spots. Next, microbiological evidence, that is positive blood cultures but do not meet major criteria. These are the main important for diagnosis of infective endocarditis. Then culture, microbiology, either we send for culture or serological examination. If the blood culture, we want to send 3 consecutive samples taken over 24 hours apart from different venipuncture sites, not same site. And if the culture is negative, then send for serological examination. Then the ECG showing there is a preceding condition are like myocardial infarction, conduction abnormalities, arrhythmias, anything we can see in ECG. In X-ray, multiple focal infiltrates and calcification of heart valves. And CBC, there is so complete blood count. It shows anemia, increased WBC count, and in blood urea and serum creatinine will be elevated, and alkaline phosphatase is increased. In this is acute phase reactants like CRP, ESR will be increased, and urine shows proteinuria and hematuria. Hematuria is one of the differential diagnosis in infective endocarditis. And the echo. Echo is the diagnostic. It shows vegetations over the valves and abscess, aneurysms, pseudoaneurysms, perforation of the valves, fistula, valve aneurysms, and dehiscence of the prosthetic valves. So the approach of the infective endocarditis. If the patient is presented with murmur, changing the murmurs, high grade with fever with chills, and there is some skin lesions, eye lesions. If you are suspecting infective endocarditis, so first low initial patient risk and low clinical suspicion. So then do the initial transthoracic echocardiography. If the transthoracic echocardiography shows no low suspicions persist, look for other sources. And increase suspicion during the clinical course, then transesophageal echocardiography you can do. If it is negative, look for other source. If it is positive, then start the treatment. And initial transthoracic echocardiography is positive, then start directly treatment. In high risk echo features are present, then do the transesophageal echocardiography for detection of the complications. If the no high risk echo features, so nothing to do for transesophageal echocardiography unless clinical status is deteriorating. It is for seeing for complications only. Then if high initial patient risk and moderate to high clinical suspicions and difficult imaging candidates, then do the transesophageal echocardiography directly. So if it is showing positive, then start straight away the treatment. If it is negative but there is a high suspicion is present, then repeat the transesophageal echocardiography. If it is positive, then do the treatment, or if it is negative, look for other sources. Or if transesophageal echocardiography is looking normal, look for either source of infection, and if it is positive for other infection, then alternative diagnosis is established. So if you are suspecting low suspicion, then direct first do transthoracic esophageal. If it is any suspicion in transthoracic, then do the transesophageal. If you are suspecting high risk, then directly do the transesophageal echocardiography, then do further prognosis. Then the treatment. The infective endocarditis is a more dangerous condition. So there is a abscess formation, and anaerobic infection and aerobic infection. So you must cover broad spectrum antibiotics, covered with broad spectrum antibiotics. Treat it early and use bactericidal agents. So if antibiotic regimen, if you are suspecting streptococcus or if culture showing streptococcus, then start with penicillin G 2 to 3 million international units 4th hourly for 4 weeks, and gentamicin 1 mg per kg 8 to 12th hourly, that is TID or QID, 4 to 6 weeks. If alternative to penicillin and gentamicin is cephalosporin, that is ceftriaxone 2 grams once a day, and vancomycin 15 mg per kg 12th hourly for 4 weeks. If you are suspecting enterococci, if you are the culture showing enterococci, then if that enterococci is ampicillin sensitive, then start with ampicillin 2 grams 4th hourly for 4 to 6 weeks, and gentamicin 1 mg per kg 8 to 12 hours or 3 mg per kg per day. And then ampicillin resistant, then give the vancomycin or gentamicin. Alternative is ceftriaxone or vancomycin. Then if it is showing Staphylococcus is sensitive to penicillin, then give the napcillin or axicillin 2 grams IV 4th hourly for 4 to 6 weeks. If it is resistant but methicillin sensitive, then flucloxacillin 2 grams 4th hourly. If it is resistant to both penicillins and methicillin resistant, that is methicillin resistant Staph aureus, then do for vancomycin is the drug of choice, that is 1 gram 12th hourly, and gentamicin 1 mg per kg 8th hourly. Then if it is patient is not responding with medical treatment, the indication to do the surgery. What are the indications? That is acute aortic regurgitation plus pre-closure of mitral valve, rupture into the pericardial sac, sinus of Valsalva abscess ruptured into the right heart, acute aortic and mitral regurgitation with heart failure, perivalvular extension of infection, septal perforation, unstable prosthesis, valve obstruction by vegetations, and lack of effective antibiotic therapy. These are the indication to do the surgery. Then if in some conditions we give the prophylactic treatment for infective endocarditis. So what are the risk? If there is a prosthetic cardiac valves are there, and previous bacterial endocarditis, even in absence of heart disease, complex cyanotic congenital heart disease, that is TGA, tetralogy of Fallot, transposition of greater heart rates, TAPVC, and surgically constructed systemic pulmonary shunts. In all these conditions, these are the high risk category, we can give prophylaxis. And moderate risk category, that is rheumatic and other valvular dysfunction, congenital cardiac malformations, hypertrophic cardiomyopathy, and mitral valve prolapse with valvular regurgitation. In rheumatic also, mitral and aortic valve involvement is the more chance to getting infective endocarditis. So if in rheumatic heart disease, if there is mitral valve and mitral regurgitation or mitral stenosis, aortic regurgitation, aortic stenosis, if there is a chance, and in non-rheumatic, that is cyanotic congenital heart disease like VSD, ASD, these are also chance of infective endocarditis is more. In these patients, we must give infective endocarditis prophylaxis. So what is the regimen we use to give in infective endocarditis prophylaxis? One is standard oral regimen, that is amoxicillin 2 grams 1 hour before the procedure, any procedure, that is dental procedures, all these procedures. And if the patient is unable to take oral medication, then give ampicillin 2 grams IV or IM 1 hour before the procedure. If the patient is allergic to the penicillin, then give clindamycin 600 mg 1 hour before surgery, or clarithromycin or azithromycin 500 mg before surgery, or cephalaxin 2 grams before surgery. If the patient is penicillin allergic and unable to take orally, then give the IV, that is cefazolin or ceftriaxone 1 gram IV or IM 30 minutes before surgery, and clindamycin 600 mg IV or IM 1 hour before the surgery. So if you are doing dental surgeries or prosthetic valves are there, valve surgery, all these conditions, we must give the prophylaxis for infective endocarditis. Infective endocarditis, the mortality rate is very much, so we must give the prophylaxis very early. So thank you.
స్టాప్ చేయకపోతే ఏం జరుగుతారో స్టూడెంట్స్ ఇంకా చూస్తూనే ఉంటారు.